I don't know. Button.
Okay. I think we've started. Good afternoon, everyone. So hope you're all feeling refreshed after the lunch break. And hope a few of you also joined the networking sessions in the breakout rooms. So welcome back to what has been an absolutely fantastic day so far. And I'm really excited about this next session as we have two excellent speakers who are going to be discussing adolescent HIV, sexually transmitted infections and inequalities. And we have Dr. Constancia Vimbayi Mavodza, who is a global and public health practitioner working in community-based sexual and reproductive health programming and interventions for young people in Zimbabwe since 2018. And Dr. Chido Dziva Chikwari, who is an epidemiologist also based in Zimbabwe, with experience developing, coordinating and evaluating implementation research studies, particularly the provision of sexual and reproductive health services for adolescents and young people. So over to them now, and please write any questions in the chat as we go along. Thank you.
Thank you very much for the introduction, Anya, and thank you for having us today. As mentioned, Constancia and I are going to be presenting on inequalities in HIV and sexual and reproductive health among children, adolescent girls, and young women. And we're going to tag team this presentation. So I'll start off by setting the scene and providing some epidemiological data on what we're finding in this space, particularly in sub-Saharan Africa. And then I'll hand over to Constancia, who's going to talk more about some of the drivers of these inequalities and different structural frameworks that we can look at them through. I hope you can see my slide deck, and this is probably one that has been discussed earlier today, or if not, everybody should be aware of. And essentially, inequality implies that equality is an equilibrium, while inequity acknowledges differences. As such, we know we are not all equal, and within that, some population groups are more disadvantaged than others, and there's a need for us to address these inequalities to improve outcomes in HIV, TB, and malaria. And addressing these inequalities is important if we are to achieve the Sustainable Development Goals outlined to leave no one behind, and also the WHO principles to serve the most vulnerable. While Constancia and I are going to be focusing specifically on HIV and sexual and reproductive health, we're cognizant of the fact that HIV, TB, and malaria are diseases of poverty and marginalization. And there are populations that experience the highest burden of these diseases, and they're chronically disadvantaged. In addition to carrying disease burden, these populations are often the poorest. They often live in rural areas where they also have least education. And Constancia is going to talk a lot more about this in her section of her presentation. As mentioned by Anya, we're going to be focusing on HIV and sexual and reproductive health because that's the space that we work in. But these learnings can be expanded to other infectious diseases, specifically TB and malaria. And one key caveat that we do want to highlight is that children and adolescents are not small adults. They're not the same as adults, and as such, our programming and interventions need to be tailored to suit their unique needs and challenges. So to set the scene with HIV, some of this data is what many of you may already know, but the UNAIDS 2022 report, which showed that 39 people were living with HIV in 2022. 4% of this population are children aged 0 to 14 years. But what we find is that 15% of AIDS-related deaths occur in this age group. There's a treatment gap when we compare children and adults. So where 77% of adults older than 15 years have access to treatment, only 57% of children aged 0 to 14 years had access to treatment in this year. There's also a need and grave inequalities among adolescents and young women, particularly in sub-Saharan Africa, which carries the highest burden of HIV. And one shocking statistic is that every 2 minutes, an adolescent or young girl is newly infected with HIV, and 78% of these infections occur in sub-Saharan Africa. Adolescent girls and young women account for over 77% of new infections among young people. And in response to this, what's shocking is that only 42% of districts with high HIV incidence have dedicated HIV prevention programs for AGYW. And I'm sure many of you are aware of the ambitious UNAIDS 95, 95, 95, 95, 95 targets. And this slide just spotlights further the differences when we compare adults aged 15 years and above to children aged 0 to 14 years. So when we look at the first 90 for people living with HIV who know their status, children are just at about 59%, whereas adults are as high up as 86%. The second 90 for treatment, children are at around 52%, while adults are much higher at 76%. And finally, the last 90, which is people living on living with HIV who are virally suppressed, we can see that children are as far down as 41%, while adults are at 70%. And so we're really missing the mark when it comes to intervention for children, but surprisingly are doing extremely well when it comes to the very same targets for older people. A lot of HIV infection among children is due to perinatal transmission, and one of the UNAIDS 2025 targets is to ensure that all pregnant and breastfeeding women are receiving antiretroviral therapy. And what you can see globally is that we are still missing these targets. While Eastern and Southern Africa is doing well at around 90% in 2021, when we look at Western and Central Africa, this is lagging behind at about 60%. And so while there are inequalities within population groups, there are also geographic inequalities within countries that need to be addressed. And now I'm just going to hone in on some of the compounded challenges that children and adolescents living with HIV face, and why we're seeing this disappointing and actually scary data for these population groups. To start off with, what we know from several studies that have been conducted within our group here in Zimbabwe by Professor Rashida Farand and others in the region is that there are many missed opportunities for HIV testing for children and adolescents for many reasons and several structural and societal barriers. Children do not access HIV testing in time. And I'll talk more about some of the barriers in terms of diagnostics in my next slide. But once children are diagnosed, they don't do well in terms of staying in care. And I'll talk more about some of the interventions that have been developed in recent years and are being delivered programmatically. Children also face a lot of stigma, bullying, and mental health challenges when they're living with HIV. HIV is often seen as a sexually transmitted infection, but we do find that in this growing population, especially when we have a youth bulge in sub-Saharan Africa, that they are different and they've acquired HIV differently, which is brought about by a lot of stigma and bullying, which affects their ability to transition to adult care now that they're living longer with their HIV infection. We also have several studies that are coming out to show that there are a lot of consequences with long-standing HIV infection, and there's a lot of HIV-related comorbidities experienced by these population groups. This includes stunted growth, cardiovascular disease, lung disease, and chronic kidney disease, among others. And so these children are facing a whole host of conditions in a system that isn't adequately equipped or prepared to support them and address these challenges. And now I am going to spotlight more closely some of the emerging programmatic strategies for addressing these inequalities, challenges, and vulnerabilities faced by children and adolescents. The first is a strategy for HIV testing, which is drawn on a strategy that was developed for adults, so HIV self-testing, which many of you might be familiar with and aware of, especially highlighted by COVID-19, where many of us could access a test and test ourselves for COVID-19. This intervention has been delivered across several countries over the last 5 years. And essentially, part of our work here in Zimbabwe identified that while the test was validated for adults, this is the oral HIV self-test kit. While it was validated for others, it had not received WHO pre-qualification for use in children. And so together with a group in Kenya, we were able to provide evidence to show the high sensitivity and specificity of the oral HIV test for children younger than 18 years. And so subsequently, WHO did provide pre-qualification for this test, but it was only pre-qualified for use by healthcare providers. And as you know, adults can test themselves, but with children, it becomes a bit tricky where they cannot test themselves. But a novel strategy that we evaluated and continues to be evaluated across several African countries is the prospect of caregivers testing their own children for HIV. And studies conducted in the last 2 years in Uganda and Zambia found that among index clients, which are adults living with HIV, 96.8% accepted to use an oral HIV self-test kit to screen their children for HIV. And among them, over 97% returned their child's test result to the health facility. As I mentioned before, we were able to show high sensitivity and specificity of this test in Kenya and Zimbabwe. And when we evaluated whether or not caregivers could correctly test their children for HIV, we found that over 96% could correctly collect oral fluid. So parents could collect oral fluid from their children correctly. And we also found that over 97% correctly interpreted the test results with a demonstration. Qualitative work across several countries highlighted that caregivers felt that this type of testing could address barriers that children faced, such as transport costs and time constraints for them to actually bring their children to the facility, and thus increase the convenience of testing. And they had the privacy to test their children in their own homes, and they felt that their children were comfortable to be tested in this environment. Caregivers felt that facility-based pediatric HIV self-testing could address limited healthcare worker availability, decrease wait times in facilities, and also increase testing coverage. And one of the really exciting things was that during COVID-19 in 2020, PEPFAR did include caregiver-provided HIV self-testing in their guidance as a way to ensure testing continues during the pandemic. However, to date, the strategy is not yet recommended as part of the WHO guidelines for testing, which further highlights the inequities in access for this group. There has also been very exciting developments in strategies for improving HIV care among adolescents and young people. And a really great example is the Zandiri model, which was originally developed in Zimbabwe, evaluated and scaled to 11 countries. And this is a peer-led model which offers community-based support for children and adolescents living with HIV. And essentially, evaluations of this model found that it improved adherence, it improved linkage and retention in care, and also increased confidence, self-esteem, self-worth, and quality of life among children and adolescents living with HIV. And one of the really exciting findings, which I believe really facilitated the scale up of this model, was that it did improve HIV virological suppression. And I've snapshot two of the main papers that you may want to look up from this intervention. And now I'm going to pivot a bit and talk about sexual and reproductive health for adolescent girls and young women. And I've spotlighted there a recent publication through the University of Cape Town that was looking at identifying the drivers and mitigating factors for adolescent HIV and SRHR health risk and what we can do in terms of programmatic practice. Essentially, what this evidence synthesis highlights is that there is early sexual risk among adolescent girls and young women, and that is through marriage and sexual violence, which results in unintended pregnancies, poor mental health, and subsequently the acquisition of STIs and HIV. This publication also highlights gender inequities and social stigma that is associated with being sexually active. So where young people are sexually active, they're not able to access and use sexual and reproductive health services because their sexual activity is heavily stigmatized, and this is done through a gender lens. And the findings from the synthesis just show and make a strong case for the need to provide protective packages and multi-sectoral interventions to improve the outcomes for adolescents and young people across health, education, and violence prevention. And this publication, although it came out in August 2023, there have been some interventions that have been developed and delivered over the last 5 years, which respond directly to this call. And I'll spotlight two of those interventions. The first, which many of you might know, is the integrated DREAMS module. And DREAMS is being implemented across, I believe it's 11 African countries, and it's an acronym for Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe. And this is a public-private partnership through PEPFAR and USAID to reduce HIV among AGYW. It's a combination package, it's layered, and it aims to empower girls and reduce risk by providing youth-friendly care and social asset building. It's got a community component, and so as part of the intervention, mobilization of communities for change is conducted in schools and communities. It includes referrals to services, including HIV testing and treatment and voluntary medical male circumcision. And it also strengthens families and provides social protection through education subsidies and socioeconomic approaches. Sadly, however, an evaluation that was conducted in 2021 showed that although there have been substantial declines in HIV incidence among AGYW, many of these began before the DREAMS intervention or package had been introduced, and may be gains of work that was conducted long before. A second intervention that I'd like to highlight is the cluster randomized trial called Chido. And essentially what Chido did was develop a comprehensive package of HIV and sexual and reproductive health services to young people aged 16 to 24 years in a community-based setting over 30 months. And then the impact of this was evaluated through a population-based prevalence survey where the outcome was HIV viral load suppression. Within this intervention, over 70,000 visits were made by young people here in Zimbabwe. And despite the high levels of testing and treatment, this trial found no population level impact on HIV viral load. The good thing is that it did increase knowledge of HIV status among youth. But one of the limitations is that we found that although we were able to reach many young people, we may not have reached saturation due to the high mobility of this group, and that potentially this community-based intervention did not reach young people that had the highest need. So a bit of negative findings, but maybe this is one of the really exciting trial findings of 2023. And this is the STITCH trial, which was embedded within the Chido trial. And essentially, STITCH is based on the premise that we focused a lot on HIV interventions, but paid very little attention to STIs, of which we do know that STIs are a risk factor for HIV acquisition and also have long-term reproductive health consequences. In many low and middle income settings, we rely on syndromic management, which has poor sensitivity and specificity for actually treating STIs, and also has subsequent consequences for antimicrobial resistance. And in this trial, diagnostic screening for STIs was conducted, and the 3 STIs were chlamydia, gonorrhea, and trichomoniasis. And we found very high prevalence of STIs in young people. Almost 1 in 4 young women tested positive for one of the 3 curable STIs at a community level, and less than 2% of young people who tested positive for an STI had any syndrome, so they would have not been treated syndromically. When we evaluated the population impact of delivering this intervention, we found that it did reduce the prevalence of gonorrhea by 43% in the intervention communities. So a very promising finding through this trial. I will now hand over to Constancia, who is going to talk a bit more about what these trial findings mean, and underlying all of them, what the micro drivers of inequalities are. Thank you.
Oh boy. Hi, everybody. As you can tell, Chido and I are together. As she mentioned, my talk here, I'm a social scientist. So I am going to approach this session to really kind of address the macro level drivers that actually can be expanded even beyond HIV, which is what we specialize in, but in other disease areas as well, right? So we're going to use a macro approach, and we're going to look at these cross-cutting inequalities. And I will use HIV as illustrative examples because that's the space that I work in. And in essence, what we are going to be talking about here is that structural, systemic, and institutionalized inequality is the system of structures that have procedures, activities, processes that disadvantage one population group over the other. So this is going to be the anchor that we'll be using throughout the rest of this session. And just for us to understand that there's an absolute need to interrogate both systems of oppression and systems of privilege that intersect and elevate inequalities. I think when we think about our individual positionalities and the things that we're exposed to and the work that we do, you realize that you can fall on either side, right? It can be a system of oppression or it can be a system of privilege, and both of which need to be examined if we're actually going to reduce inequality gaps. So in order to do this, I'm going to use a power relational framework. This is actually a gender analysis framework, but I hope we all know that gender is actually one of the key drivers of inequalities, but it's one of my favorite frameworks that I like to use when thinking about inequality or inequity, because it lends itself to also to intersectionality and kind of the structural factors that are different amongst populations and help us to examine those differences better. So we're going to look at access to resources. So who actually has the resources to do programs, policy, research in HIV, and these resources can be financial, human, social, and professional capital. We're going to look at division of labor. So who's actually doing the work, who's operationalizing the programs, the research, the trials. Chido and I, as you saw in her presentation, talked a lot about the trials that we've done. So who's doing the work? And what does that mean? And what does that translate for the benefits that become available when we've conducted this research and these programs? We'll also look at decision-making abilities. So who makes the decisions about what kind of programs we end up doing? Who makes the decisions about policies and guidelines? And how does that trickle down to real-time effects to communities, participants, beneficiaries of our programs and our research? And then we'll also look at social norms, cultures, and values, and how these shape power and access and access and ability. And you will realize, and you'll see throughout the rest of this talk, that actually these four components intersect. You'll find that, for example, a decision that's made will influence the division of labor or the access of resources, right? So they don't necessarily exist in isolation, but it's if you're ever thinking about doing research or interrogating inequity or inequalities, this is one framework that's quite helpful and helps you to engage with that kind of material. So when we're looking at access to resources, right, it's this idea of who has what, right? And this can be education, information, income, benefits, time, space, or even social capital. And I think you would have heard in our introductions, I am Zimbabwean. And you will realize that there is definitely inequitable distributions of money, access, and even professional power. And I want to use the example of our research funding structures, right? It is completely difficult for someone who looks like me. I'm a young Black African Zimbabwean woman. And for me to be able to access independent research funding is almost impossible because of my positionality and all of the identities that I occupy. Yeah. And I acknowledge my privilege, right? I was educated in America and I have a British degree. And yet the British economy has been built on the back of my ancestors, but I cannot access that British funding, right? That's inequitable access. And then when you start to think about accessing human and structural resources, this one is a good point, right? So Chido talked about it, about how AGYW have higher elevated risk of HIV infection, right? So compared to their male counterparts in Zimbabwe, 15 to 19-year-olds have 6 times the risk, and 22 and 4-year-olds have 4 times the risk. That's an inequality gap in HIV outcomes. And to respond to that, then we've had DREAMS, we've had the Global Fund AGYW program that have been done as a response to these inequality gaps, right? And that's an approach that's actually trying to reduce those inequalities. But I will delve a little bit into the mixed results of these programs later on, just as we're engaging with some of these components and structural inequalities that perpetuate disadvantage. And then another example that I want to use when we're thinking about access to resources and inequalities is the COVID-19 response. I mean, I think if you read the WHO report on the inequality gaps in HIV, TB, and malaria, it's very clear that COVID-19 exacerbated these gaps, yeah? However, if you think about the COVID-19 response here in Zimbabwe, we didn't really know about COVID and what was happening until later on, right? The global north kind of heard about it first, experienced it first before we were doing it. And I've never seen a vaccine that was developed and sent out so quickly than the response that we had with COVID-19, right? When you compare this to the Ebola response, right? Ebola started in Western Africa. It started on the African continent, but the response to Ebola was slower. Yeah. And there is an unequal value that is placed on people's lives that was illustrated in how the response to COVID-19 happened and the responses to Ebola happened. And if you think back to the history of the AIDS crisis when it was happening, again, this trend of the unequal value that's placed on people's lives also came out. Yeah. It was men men who are having sex with men. And if you look at South Africa's history and the HIV response there, again, the responses were slower, decisions were made that showed us that there is an unequal value that's placed on people's lives depending on where you are from and your geographical location. Again, showing us the kind of inequalities that exist that are quite structural and embedded that end up influencing our progress towards positive outcomes. And then to look at decision-making abilities, and I want to go back to the example of trials and even access to resources, right? So when people from their countries of origin, when we cannot access research funding, usually we end up with PIs who are foreign, yeah? And what ends up happening is with a lot of our programs and our trials, the funding comes with terms and conditions from the funder, right? That's already one decision that has been made. And the situation is made even more complex when you have communities or beneficiaries or potential participants who think the intervention or the service or the trial should be going in a different direction. But because they are not directly the ones, they're not the holders of the money. It is held by the PI who was selected by the funder. Their voices and their knowledge is sometimes diminished and reduced, in part because also the PI is just obligated to meet what the funder says, yeah? So this is kind of a complexity that ends up existing, all because there is a hierarchy of who is being valued and whose knowledge and whose voice is being deemed to count when it comes to accessing resources, and in this case, financial resources to run a program or a trial. Another thing that I want us to be thinking about is who decides the research or program outcomes. And I want to use the example of a trial because Chido and I have been working in the Chido trial for over 5 years. Yeah. When you're trying to decide the trial outcomes, right, and what they are and what they're going to represent, it's going to include the researchers, your biostatisticians will calculate the power and will figure out what we mean by improved viral load suppression for the Chido trial. Yeah. But a trial usually happens. Chido we were implementing for 2.5, 3 years. Sometimes you have trials going for 4 or 5 years. When we do formative work with people in the communities who are going to be participating in these trials, usually we're asking them, what kind of intervention do you want? Rarely are we asking, what does a successful outcome look like for you? And we don't include whatever version of successful outcome looks like for them in how we define our trial outcomes, right? So that's, again, whose voice and knowledge counts, and also the decisions that we make when we are conducting these trials. And what ends up happening, and I'll give a very specific example with Chido, for example, is the unfortunate thing with trials is that they're temporary, they're going to end. There's an end date, and there's very rarely funding for the components of the trial that work. Yeah, a funder is going to fund until the trial ends. But when you've spent 2.5 to 3 years with trial participants and they have components of the trial that are working for them, especially if it's a service, right, or a public health intervention, there are parts of the trial that people are going to find highly acceptable and want to go on. But we're going to stop that, right? So now we're almost removing from people something that they had gotten used to that was important, that was making a difference in their well-being and in their lives, because the way that we have decided and valued and said trial outcomes should be defined didn't account for their voices and for their knowledge. So that's just one of the ways that we then continue to increase inequality gaps, and sometimes maybe even why our trials end up not having positive outcomes. And maybe why, for example, in HIV prevention, we still see that our risk for AGYW, for example, continues to remain very high, no matter what kind of interventions we are putting in. And then just to conclude for our decision-making abilities, this idea, we know that historically aid programs have reflected legacies of colonial practices. And there's been some progress and some shifts. I know, for example, PEPFAR has started to say that they want to fund 70% of local organizations and are making efforts to do that. But that doesn't always equate to decision-making power. Yeah, sometimes we work with organizations where they actually feel like they can't make any decisions, even though they're quote unquote a local organization and have become the holder of the funds. And lastly, just on this kind of macro level systemic approach that we're working with, this idea of women, of gender. Chido started to talk about kind of how gender is a player in inequalities. And we know that there is poor representation of women in health policy and decision making. And we'll delve a little bit deeper into this point in the next section, where we are going to be looking up at division of labor. So who is doing the work? Yeah. And I'll stick to my trial programs example here, right? And you find that who's operationalizing trials and actually making sure, or even programs, and making sure that they're running on the ground. It is usually people who are in the communities or in the countries that are housing these interventions, where these interventions are anchored. However, one of the questions that we need to be asking and engaging ourselves with is, are the benefits of the research programs and policy work equally valued and distributed? And I'll give an example, and this has come up a lot if you've been reading, for example, the decolonization literature, or even literature on diversity, equity, and inclusion. And you will realize that, oftentimes when we're doing research or trials, right, we tell our participants that the results of the trial might not necessarily benefit you directly, but they're going to have an impact on people of your population. If they're young girls, you say, some other young girls, depending on the results, will benefit from this. They might not, you might not necessarily directly benefit if you're participating in this, right? That's like an ethical obligation, and you're explaining what this means to become part of a trial. However, when you then find that research participants are unsettled or disgruntled by not benefiting, by not getting anything, right? And what this looks like, we have to realize that this is not a misinterpretation of what they were told by the researchers. Yeah. What this means, and what we have to think about, this is coming from a history of extraction. Yeah. So when we take their responses and we convert them into data that we then go and we publish in the Lancet and these prestigious journals, and us as researchers, we get the accolades, and they tell you Constancia has done good work and my professional and academic career flourishes. That's like a very valuable benefit of doing that research, right? But the research participants are not necessarily getting the same level of value for participating, for their responses being extracted and taken into data to be published for an academic audience. And I think it's something that we all have to grapple with and engage with when we are doing research, to try and figure out how do we ensure that our participants, or even programs, our participants, our beneficiaries, our recipients, are actually getting equitable value from the research and the work that we're doing. And then to link to what I was saying about how there's poor representation of women, we also know that the division of labor in the health workforce is very inequitable, right? Over 80% are women, and yet they occupy less than 25% of leadership position. And thinking about those interlinkages around the 4 components that I was saying, this means that there are going to be less women who are actually making decisions, even though more women are doing the work within the health workforce and health systems. Again, related to that is this idea of the feminized burden of care, right? I think we all know that the caregiver role disproportionately burdens women. And when you think about, I think Chido gave us examples about, for example, children who are born with HIV, their caregivers are mostly, almost always women as well, or being pregnant, whether you're living with HIV or not, the burden of that pregnancy is also almost always on women. One of my favorite examples that I always give is the role of community health workers in the HIV pandemic. And they were the people, they were mostly women, they were the people who were doing door-to-door, house-to-house, ensuring that people were taking their art. If somebody was falling ill, they were ensuring that they were treated until they were well again. In essence, they literally anchor and hold primary health care and are probably responsible for all the shifts in HIV outcomes, and yet they still remain the lowest rung of the hierarchies in health providers. In most countries, they are actually volunteers. They are not paid, right? So again, this idea of feminized burden of care, of remuneration that is inequitable, that again just continues to show us the inequality gaps and how big they are within a health system and not necessarily disease groups. And then I'll then also talk about social norms, cultures, and values, right? And we know that they shape us and our understanding and interpretation of medicine, health, disease, and infections. And they're present almost everywhere, yeah? So even in kind of these legalized, institutionalized guidelines and accountability mechanisms that are somehow supposed to be objective, you'll realize that norms, cultures, and values actually participate in the curation and operationalization of these. And I want to take about two examples that we have in Zimbabwe. So comprehensive sexuality education in Zimbabwe, for example, is very abstinence heavy. So you'll find that you'll have Ministry of Health or even other partners or organizations really trying to advocate for it to be a little bit more representative of all, for example, prevention or sexual and reproductive health that young people may need, but that's not the case. And what ends up, the irony though, is that we also have a School Health Policy Act that allows young people who are pregnant, or young women or young learners who are pregnant, to continue going to school until they give birth, and then they go on maternity leave, and then they come back. And yet there is no more evident illustration of being sexually active than a growing pregnant stomach. Yeah. So you have these two things. There's an acknowledgement that young people are having sex because if you're pregnant, you can continue. But then you also have a comprehensive sexuality education curriculum that's still preaching abstinence. Yeah. So you can see how social norms, and that's partly because in my Zimbabwean culture, we kind of don't talk about sex very openly. And you can see how that has then become infused in guidelines and curriculums within the school environment. And then more recently, we've had the age of sexual consent been moved from being 16 years old to 18 years old. The bill was just approved about 2 weeks ago. And we have an AGYW program that is trying to improve access to HIV and sexual and reproductive health services for young people aged 15 to 24. Yeah. And now you have the sexual consent that's saying you can only sexually consent when you're 18. So we're going to have young women who are aged between 16 up to 18, who ordinarily could have gone to a clinic or a health facility to ask for family planning, which implies you're sexually active, or even HIV testing, or even PrEP, which implies you're sexually active. And they're not ordinarily going to be able to access services. Yeah. And this is the conundrum we currently find ourselves in, which potentially, probably if we had this conversation 3 years from now again, is going to increase inequality gaps in our HIV prevention outcomes between young women and young men. And then, of course, we'll always have these, to go back to health workers, we'll have these conflicting norms, right? For healthcare workers, for example, and especially for female health workers, or ideal worker norms are often at tension with traditional cultural expectations. So sometimes you're kind of expected to work long hours, be always present. But if I give an example, if you're a woman who's just given birth, your caregiver roles, if you're caring for even parents, remember we talked about how the burden of care is usually on the women. That's like a traditional cultural expectation that sometimes will conflict with the kinds of work and the norms that at work and that you are supposed to be doing. And lastly, before we kind of go into what are we going to talk about it, how are all these things influencing, interacting, intersecting with access, appropriateness, acceptability, and even availability of services. And hopefully throughout this session, you've kind of seen how some of these macro level inequalities do end up influencing services, right? But I think what's quite clear is that for us to tackle inequities, we need to go beyond thinking about increasing service provision or coverage or reach to disadvantaged people, but also engaging with these very macro level, systemic, deeply penetrative inequality factors that sometimes are quite implicit, but need us to engage with them and to be aware with them. And then reducing and eliminating unfair inequalities is going to require us to expand those services, but also to have action on the social, economic, political, environment, and commercial determinants of health. So in conclusion, what can we do? And we think it's important for us to recognize how systemic structures, norms, and processes will preference certain differences over others, right? So there will be hierarchies, and people, institutions, organizations, communities, countries will be placed on some hierarchy. And I think us acknowledging that as a first point might help us be more aware and explicit about the potential inequalities that might end up existing. And also to learn to identify the degrees of privilege and recognize how multiple identities can intersect in different social systems, and then have interventions that actually accommodate those degrees of privilege. And then build the capacity to use our privilege and power to benefit the health and well-being of the systems that we inhabit. I would like to think that all of us, let's go with maybe because we have some level of education, means we do have privilege and power. And if we can use that to actually address, engage, and not shy away from some of these inequality factors, maybe we'll have a chance of actually improving, of reducing inequality gaps in our disease areas. And also to tend to the impacts of historical and present day forms of oppression and trauma, and to tend to further contextualize research to understand why such inequalities persist, what drives them, and how interventions can be designed to effectively reduce inequalities. And then also this just thinking about how do we remain sensitive to these inequalities in ways that foster acknowledgement and action to address them, which I think is something that I've just really talked about. This idea of pass the mic. If you work in advocacy, it's a term that's used often, but this idea that you do not always have to be the one speaking or deciding. As much as possible, if you can have the communities, the patients, the clients that you're working with actually represent and speak for themselves and advocate for themselves, then the better, right? I'm a social scientist, so I'm going to tell you to be reflexive and to self-reflect, to recognize all of our roles in reinforcing systems of oppression or even of privilege, and to take actions to dismantle existing power structures so we can achieve equity and diversity in global public health. Also to interrogate and understand how power is negotiated and changed, and more importantly, to accelerate and put forward efforts towards ordinarily disadvantaged populations who are most at risk and vulnerable. That is going to be essential if we're going to end our AIDS, TB, and malaria epidemics. Thank you very much for your attention. We will take some questions if we have time.
Thank you so much to both of you for an absolutely fantastic session. Really lots of food for thought there, and a lot of advice on kind of ways to have a positive impact. I think you actually answered one of the questions there, Charlotte Brown's question. But I'm just going to read out a few of the questions in the chat, if that's okay. I'll try and combine, we have about 10 minutes, so I'll try and combine some of the questions. So firstly, for Chido from Helen and Becky. So both say fascinating work and fantastic to hear about the Stitch trial findings. So Helen asks, are you planning any follow-on studies to look at reinfection rates? And Becky asks, do you know whether many of these strategies that you implemented have continued as practice? And I think that was touched upon to some extent by Constancia as well.
So I'll try and answer Helen's question. So we did not look at reinfection in the population prevalence survey, but we did look at reinfection among those who came back for testing in the intervention, and you can see some of those findings in the paper that's published in the Lancet HIV. And essentially what we found is that there is high rates of reinfection for chlamydia, and this is primarily due, I think, to the high prevalence of chlamydia in the population. We are advocating for these interventions to be included in programs, and this is including the Ministry of Health and also donor-funded programs. So we recently had a workshop with the Global Fund that was looking at HIV and STI integration and how we can do that and how that can be funded within our context. We've been working with programmers, but when it comes to STIs, similar to the example that Constancia gave for COVID-19, is that we just don't have proper diagnostics. The diagnostics that we have are hugely laboratory based, they are expensive, and they take time to process, which means in these areas that I highlighted in my first slide, where they're rural, they're poor, it's not likely that these tests are ever going to reach them. And so we do need new diagnostics, better diagnostics, so that we can take forward some of these really, really important interventions. And like Helen says, they will improve outcomes for these newborns in the future. And so there is a great need.
Thanks. And more praise in the chat. I hope you can both see it. Wonderful reflection, so much to consider and reflect on, many calls to action, powerful presentations. It certainly feels like we're in a place of privilege. So we have a responsibility to take action, a real challenge to know how best to do this. Thank you. So a question from Katie McDowell. Again, fantastic presentation. So important to think about power relations and ensuring our work does not perpetuate problematic power dynamics and structures. Sorry, that's a comment rather than a question. But I had actually a question for Constancia. So I work in maternal and infant vaccines, and obviously was very shocked by the COVID vaccine inequity, which you've already touched upon. And one of the strategies that we've been discussing, or that it has been discussed to tackle this, is about improving vaccine and pharma manufacturing capacity in the African setting. And I just wanted to ask, from your experience on the ground, what do you think about this approach? And also, do you think it would get support from local communities?
Yeah, I'm trying to make the link between local communities and vaccine manufacturing, but I will say there is support from the Africa CDC. It is already working on that. In my other life, I work with the Mastercard Foundation, and we've given quite a lot of money to the Africa CDC to actually ensure that the African continent can produce its own vaccines, with kind of the possibility of producing other medicines, right, depending on emerging needs and potential crises that might happen. So there is a lot of investment right now in capacity strengthening of African scientists to ensure that they are actually able to do this on the ground. So I think in that way, there is some reduction of that gap, right? That we're not waiting for Pfizer to produce it and then bring it to the continent. It will be very much homegrown in the motherland. And if we have another global crisis, then at least the continent can have its own response before we even start to engage with a more global response. We called in a little bit earlier, and we were talking about where you guys were discussing vaccine hesitancy. And I think that's always going to come up. I think depending on our sociocultural norms and how we understand medicines, and especially in issues of crises, it's very hard because so much is going on and you're trying to process a lot of things. So there isn't always necessarily time to socialize or sensitize or mobilize communities to accept something that we as scientists think is going to work, right? We're like, if you get the vaccine, you're going to be fine. And biologically or pharmacologically, we can explain it. But trying to then sell that to my grandmother who's in rural Zimbabwe is a whole different conversation. So I think having it on the continent is really, really great. My last point that I will say, which is a strategy that's quite fascinating, that is, I'm going to say PEPFAR or USAID funded, that's going on with kind of HIV prevention technologies. And what they've done is they have done a long-term investment that actually starts engaging communities at the lab level. So whilst the technology is still in the lab and being discussed, and they'll be bringing the findings and what it means from like phase 1 trials, from what it can mean and what it entails back to the communities who will eventually use that trial in the, I don't know, 15 or 20 years that it will eventually, or that drug in the 15 or 20 years when it will eventually happen. So it's a very resource intensive investment, but that could be one way of ensuring that the communities that we expect and anticipate to engage with our vaccines are actually taken along the entire route of the production of those vaccines until they are taken to them for use.
Fantastic. I think sadly that's all we have time for. I know I would love to continue the conversation, and I'm sure you both wouldn't mind if people email you if they have any further queries. But thank you so much. A lot of interesting stuff to think about. Thank you again. And I'm going to hand over now to Becky and Laura, who will be leading the plenary on global perspectives on inequality and infectious disease. And I'm sure many of the themes that you guys have started talking about will continue in that session. Thank you, everyone.
Oh, thank you so very much. Really challenging talk, and really appreciate your insights. Thank you. Now moving on to our next plenary, and myself and Laura, who's another member of the committee, will guide us through. We're looking forward to thinking more broadly about some less famous conditions now, and in a short while we'll do a bit of a deep dive into neglected tropical diseases with Professor Amaya Bustinduy. But before we invite her to the stage, we've got the pleasure of hearing from Dr. Oghenebrume Wariri, who is going to explain the increasingly challenging area of inequality in childhood vaccines, following on really nicely, I guess, from the talk that we've just had. And Dr. Wariri is a clinical research fellow in vaccines and immunity at the MRC unit, the Gambia, as part of the London School of Hygiene and Tropical Medicine. And his research focuses on vaccine epidemiology, particularly in West Africa. He sits on many important panels, many, too many for me to say, championing the cause of vaccines. And it's a real joy and privilege to have him with us today. So I'll hand over the stage to you, Dr. Wariri.
Well, thank you very much. I hope you can see my full screen.
We can see it in presenter view, but that's okay.
Okay, good. Okay, that's fine then. Okay, good day, everybody. So I'll be taking us through inequalities in childhood vaccines, and just to mention the fact that, which are clear to all of us, that immunization is the most cost-effective public health intervention for the control of infectious disease. And putting some numbers to it, we know that for every dollar spent on immunization, the return on investment is about $16. And if you even consider the broader benefits of vaccination, that can rise as high as $48 per every dollar spent on immunization. In terms of deaths, immunization saves about 4 to 5 million deaths yearly. We have had successes in 1978. Smallpox was eradicated due to vaccination. Polio is on the verge of being eradicated, with about 2 or 3 countries still having the wild type of polio globally. So, but despite these good things I've just read, that there are also the bad side of things, which we know that in 2020, about 23 million children did not receive any vaccines at all, meaning they were 0 dose. And that number was the highest as compared to last decade, which was the highest number then before there was 2009. And in addition to that, in many countries, childhood vaccine coverage continued to vary by geographical, socioeconomic, and demographic factors. And this highlights inequality in the delivery of childhood vaccine with potential consequences. And unsurprisingly, there have been measles outbreak in many parts of the world, even in settings where coverage to measles vaccine is quite high. So I will take us quickly to why is it important to ensure that we ensure equity in childhood vaccination. I will start with Europe first of all before talking about West Africa. Compared to 2017, the number of measles cases in Europe tripled in 2018, and this was despite having high vaccination coverage rate in many countries across Europe, and 47 out of the 53 countries in Europe reported over 80,000 measles cases. There were almost 100 deaths. In specific number, there were about 72 deaths, and this was the worst measles epidemic in Europe in a decade before 2018. Of course, there are outbreaks currently ongoing in certain parts of Europe, but looking at the 2018 outbreak, almost every country, as we can see from the chart here, had cases. But again, just to highlight the fact that this outbreak was due to a resurgence or a build-up susceptible individuals in certain communities, in certain countries where people who were probably poor, who were disadvantaged, who were migrants located in certain communities did not receive their measles vaccine, and that build-up of susceptible people led to a decrease in health protection, and measles does not respect national borders or state borders or regional borders. With outbreak in such isolated communities who were disadvantaged, of course, is spread across many of these countries in Europe. And of course, this highlights the fact that ensuring that coverage is high is one thing, but ensuring that it's high across border, it should be our goal. So I will take us to West Africa, looking at in a different context, also with different reasons for measles outbreak in this setting. I will talk of the look at Ebola outbreak happened in Guinea, in Sierra Leone, in Liberia. That was in 2015. But because of the measles outbreak, one of the fallout or secondary effect was the fact that there were reduction in immunization rates in these settings where vaccine coverage rates were not the best compared to other parts of the world. But what was striking in these three countries I just mentioned was the fact that this drop in coverage was even more worrisome in certain isolated communities that were hard to reach, that had the highest number of Ebola cases, or people who were already disadvantaged had the highest number of children who ended up not receiving their vaccine. And these communities also cross borders across these three countries in West Africa. As this paper that I have just shown here show that there were accumulation of susceptible children in those communities, and it was spread across these three countries. And they predicted that an outbreak will happen due to this inequality in terms of coverage of measles vaccine. And of course, a year later, in 2017, there were outbreaks in Guinea. Of course, there was also outbreak in northern part of Sierra Leone. So this highlights the fact that inequalities in vaccination coverage can result to real life dangers in having diseases like, in this case, measles, outbreak that could have been prevented if we ensure that all children receive measles vaccine the way they should receive it across board, across the country. So thinking of inequality, I think it will be important to understand what drives inequality in childhood vaccines. And I know that Professor Mahmoud have talked a lot about what drives inequality in general, and so that has laid a good foundation. But in terms of vaccination, I will use the socio-ecological model of factors that influence inequality in childhood vaccination developed by Public Health England and published in 2021. So generally, there are factors in terms of intrapersonal factors, interpersonal factor, community level factors in terms of how gender norms, for example, stigma, discrimination, how these drive ability to accept vaccine or not accept. There are also policy factors in terms of funding. How do we fund our immunization system? Do we fund it in a way that we inadvertently disadvantage certain populations or the other? And of course, there are institutional or health service factors in terms of where we deliver our vaccines. How are they organized, for example? What is the level of staffing we have, for example? What is the scheduling of vaccination, for example? But if you want to be more specific, this can be seen like the usual things that drive inequality in terms of sex, in terms of ethnic minorities or migrant population, in terms of religion, in terms of geography. In this part of West Africa, that's quite important. In terms of rurality, some communities are quite far away from the center where access can be very difficult or they are remote. Of course, there are broader issues of disabilities. Disability in certain parts of the world, especially in West Africa, such groups might not be thought of when we are designing our immunization systems, and that can result in inequality. Of course, the two big ones I would like to talk about is income levels in terms of wealth quintile. If we divide the population into the wealthiest and the poorest, the difference between the child of the wealthiest person in the population and the child of the poorest person. Of course, we all know that maternal education is a key issue that has been talked about in the discourse of inequality, whether it's in NCD, whether it's in any form of inequality. But it is not all doom and gloom, because there have been global strategies that have been set up to ensure that immunization systems, wherever they are delivered, everybody get access to what the system ought to deliver. There was the Reaching Every District strategy called the RED strategy developed by the WHO, UNICEF, and other partner. And the aim of the RED strategy was to ensure that every district in every country has some minimal level of vaccine coverage. I think the RED strategy was talking of 80% coverage across every district. So WHO and all partners have thought of inequality in immunization and have built that in. In addition to that, there's also the Global Vaccination Plan, the Dziva, which, of course, one of the key phrases, he said, it's a world where everyone, everywhere, at every age, fully benefit from vaccines, acknowledging the fact that there are obstacles that could prevent certain people from accessing vaccination, and we have to ensure that we cut out such kind of obstacles. In fact, the Dziva report put a particular kind of benchmark, ensuring that differences in vaccination coverage between groups should not be more than 20% points. For example, if the coverage in the richest quintile is 80%, the coverage in the poorest quintile should not be less than 60%, clearly acknowledging inequity and ensuring that we don't perpetuate it further. Also, the current immunization agenda 2030, of course, the key phrase there is a global strategy to leave no one behind, also ensuring equity gaps are closed. In addition to these global and really big strategies, even organizations like Gavi, Equity underlines the work they do. There are groups like the Equity Reference Group who also ensure that or talk about, equity must be the backbone of whatever we do regarding childhood immunization. So in the next couple of slides, I want to look at the state of inequality in childhood vaccines. I will start globally first of all. I will go to West Africa to show some of the work we have done in measuring inequality. Then I will end with the Gambia, where I currently do some work and talk about what is the pattern of inequality, what's the state of inequality, what's happening, and what can we learn from the patterns we are seeing. So globally, so the report I'm showing here is the WHO State of Inequality in Childhood Immunization. It was published in 2019, and the key findings from the report shows that overall, so this report looked at 69 low and middle income countries, looking at inequality over a 10-year period, and tried to understand what has happened to inequality in childhood immunization in the last 10 years prior to 2019. So the key findings that overall inequalities seem to be reducing in these 69 countries compared to 10 years prior to that time. However, while that is reducing intra-country inequality, the key things that have driven inequality in countries are issues of wealth. So comparing the coverage in the wealthiest population to the poorest population, there is a clear gap. And also maternal education in terms of those who have secondary education or above compared to those with no education, the differences are clear. But in terms of whether people live in urban area or rural area, as we can see here, or whether people are children were males or females, the gaps were really, really very close, highlighting the fact that issues relating to maternal education, issues related to wealth in countries are important drivers of inequality globally in these 69 countries, and they must there should be strategies developed to bridge these gaps. And also one thing the report showed was that vaccines that are given in multiple doses, for example, the DTP vaccines, those vaccines have equity gaps in them compared to single-dose vaccine, and also vaccines that are given later in the immunization schedule, those given at, for example, 6 months or 9 months or after the first year of life. So the report also now grilled it down to try and look at, okay, among these 69 countries, let's look at the 23. So they had 23 countries they called priority countries, because these countries had coverages that were really, really, really poor. And this included, for example, countries in West Africa like Mali, Guinea, Nigeria, Liberia, and those kinds of countries. So this figure here is trying to show that, okay, in these 23 priority countries that have very poor coverage, if we want to increase their coverage, if we can bridge economic-related inequality, which is between the poorest and the richest, if we ensure that the coverage among the poorest is equal to the coverage of those in the wealthiest category, these countries will make significant progress in bridging equity gaps. So just highlighting the fact that just by trying to bridge equity gaps, these countries will make significant progress in ramping up their coverage. And the dark blue areas shows where currently their coverage is, and the lighter shades of blue shows if they bridge those gaps, where their coverage can increase to just by bridging economic-related inequality. We've not talked about maternal-related education or other drivers of inequality, highlighting the fact that inequality, if we can bridge them, we can also ensure that coverage overall increases. So I will go to West Africa, and the next couple of slides will show some of the work that I have led in West Africa to measure inequality. So the first was a work we published in the BMG Global Health in 2019, where we tried to look at, okay, what is the progress? We were trying to look at 15 West African countries and look at their progress towards achieving the Global Vaccine Action Plan, which had clear milestones of saying coverages in one group should not be more than or less than 20% in the best performing group. So we use that metric to look at the sex of a child, where they live, rural, urban, maternal education, looking at the most educated, secondary education or more, and no education. They're looking at wet quintile, those in the topmost wet quintile and those in the lowermost part of the wet quintile, looking at BCG and DTP. So what we found are similar to what the global report by WHO reported. We can see from child sex, is the inequality are really, really very little between boys and girls, but issues of maternal education, we can see wide equity gaps there. Wet quintile, again, very wide, but also striking. Remember, I mentioned some priority countries that included countries like Guinea, countries like Liberia, Mali, Nigeria, and those countries. If you look at this, but even Cote d'Ivoire, the widest equity gaps are in those countries. Look at Nigeria, for example, very wide. So one box here is 20% points. Remember, the target is to ensure that you don't have more than 20% points between the best performing and worst performing, depending on which pillar of inequality you are looking at. So you see Nigeria, for example, Guinea, for example, is one of the priority countries. Cote d'Ivoire, for example, wide equity gap, both for BCG and both for DTP3. So this next piece of work we were looking at, there's a plan by the WHO to ensure all countries eliminate measles by 2023. At that time, that was the target they had at that particular time. So we wanted to look, okay, what is the progress of countries in West Africa in reaching this target? So we looked at these 15 countries, because West Africa has the economic community of West African states where people can travel across borders. And we know a disease like measles will not respect borders. If there's gaps in one country, it can easily translate to outbreak like we saw in Europe, or we saw even post-Ebola around that part of West Africa. So what is clear is that in addition to what I've shown previously, countries like Guinea, Nigeria, look at Cote d'Ivoire, they have the coverage needed to ensure that you reach at least 95%. They were far away. Then the larger the bubble, it shows the larger the number of people. Nigeria is understandable because of, it's a large country. The birth cohort is maybe in excess of about 20 million per year, if I'm correct. So that is understandable that the numbers will be high, in addition to very low coverage. But on top of that, if you now break it down to, okay, let's look at intra-country, intra-regional. So a country like Nigeria, where coverage is high on the one hand, but you have countries doing well in that same country. But of course, in the northern part of the same country, you have countries that coverages are less than 20%. So showing large equity gap. But countries like Ghana, who are close to the 95%, have everything is almost homogeneous. So highlighting one of the points that I showed previously, where I said if you close equity gap, you are also going to increase coverage inadvertently by doing so. So look at Ghana, coverage is close to the 95%, which is expected every country should reach. And you can see that almost all the regions in Ghana have about 80% and above. So again, highlighting inequality can drive coverage down. So this figure here, so we now try to look at, okay, these countries taken together, if you look at geographic inequality compared to the countries who have high coverage, the countries who are dark green are countries doing very well. Look at Cape Verde, for example, the Gambia, for example, Ghana, for example. The geographic inequality in those countries are actually less than 20% point, which is what is expected, which is what we want to achieve. And of course, highlighting the fact that with higher coverage, your inequality is going to narrow. So I want to end with looking at the Gambia where I currently work. I just highlight the fact that immunization in the Gambia is really quite fantastic. I mean, childhood immunization. Country is about 2.4, 2.5 million people. The immunization coverage rates can be comparable with what you will find in some parts of Europe, maybe some parts, even in the UK, for example. Coverages have been above 90, 95% pre-pandemic. And of course, you can see there is a decline after the pandemic started. So what I want to show subsequently, despite this good picture, nationally things are fine. Recently, in 2023, we tried to understand, okay, coverage is high. In settings of high coverage, there are better quality indicators you now look at, things like timeliness. How timely do people receive vaccines, for example? Let's take MCV, measles-containing vaccine, to be taken at 9 months in the Gambia. If counting coverage, right, we look at children who are 23 months and below. So which means that I do a survey and I ask people who are 22 months, did you take your measles vaccine? They say yes. Overall, we'll say we have 95% coverage. But how many children actually receive it as of when prescribed? Because if the more they keep delaying, the more you have susceptible population that can actually get measles infection before they get vaccinated. So this chart was looking at that. Okay, what is the timeliness of vaccination in the Gambia and how is that distributed geographically? Trying to understand if there's inequality in terms of why national figures are fine. What if you break that down? So the chart on the left are showing a 1 kilometer by 1 kilometer grid of how the inequality is. But what is clear, if you look at on the right, is that the part towards the eastern part of the country, which is more rural overall, has more delays in the Gambia for both the third dose of pentavalent vaccine and the first dose of the measles-containing vaccine. But the part where towards the more urban area or the more central part of the country where access is quite easier, timeliness is better in those areas with lesser proportion of children being untimely in those locations. Again, highlighting that in a country, things might be looking very well, but you need to find a way to really narrow it down to looking at the numbers geographically to understand which areas are more vulnerable or which areas are not doing well. To put it in a chart, just looking at 3 vaccines we look at. The birth dose of hepatitis B vaccine should be given within 24 hours, Penta 3 and MCV 1. Again, for all those 3 vaccines, divided it into tertiles, the most eastern part of the country, in this part called Basay, had, for all those vaccines, they were within the highest division in terms of those with delays. The more urban areas in terms of Kanifing, where it's more urban, or the Banjul area, which is more urban, you can see that delay seems to be less. Highlighting geographical differences could sometimes drive inequalities, and if you don't measure them quite well, you will not be aware. You might be basking in your euphoria that, nationally we're doing well, but there might be vulnerable areas across the country that might need intervention. So just to summarize, just to conclude, I would say that vaccination programs should be designed to ensure that every child everywhere has equitable access to vaccines, and not just looking at the overall coverages that we will have, but ensuring that across divisions of gender, of whether people are migrants or not migrants, whether people live in hard to reach or not hard to reach, they should get benefit of vaccines, and we should routinely measure inequality so that disadvantaged subgroup can be identified. Globally now, there's a drive towards zero-dose children, people who don't receive vaccines at all. We should not just know that the proportion is 20%, but we should know where they are specifically, as shown in this map. And lastly, we should prioritize coverage across subgroup location in terms of where people live and socioeconomic status. And with that, I will say thank you for listening and thank my funders for supporting the work I've done in the last couple of years in West Africa. Thank you.
Wow. Thank you very, very much, Dr. Wariri. It was very insightful talk. I imagine everybody was shocked by the statistics that you gave at the beginning, about 23 million unvaccinated children. So thank you for presenting that to us, giving us lots of food for thought. If we can encourage participants to please pop their questions in the chat, that would be great, so that we'll be able to ask you those in the panel discussion in a few minutes' time. But I'll hand over to Laura to introduce our next.
Thank you so much, Dr. Wariri. It was excellent. I am so pleased now to welcome Professor Amaya Bustinduy to the stage. Professor Bustinduy is a pediatric infectious disease consultant in the UK. She leads the schistosomiasis clinical research group at the London School of Hygiene and Tropical Medicine. And she's here to tell us all about the tropical infectious diseases that we don't hear much about, but which do cause a significant burden. And also talk about the inequalities that these cause for children worldwide. Welcome, Professor Bustinduy.
Thank you, Laura. I don't know about all of them because there's quite a few, but let's get on with it and we'll see how far we get in 20 minutes. Hello, everybody. This is a really, really exciting meeting to attend. Just bear with me 2 seconds and hopefully this will work. Can you see my screen?
Yeah.
Can you see my screen, Laura? Yes. Okay, great. So yes, thank you for the introduction, for having me here, for having this kind of events, which is really exciting and needed to keep the momentum in child health, international child health. And of course, to talk about the neglected tropical diseases is talking about not one disease or two, but actually 20 that have made the list. And you will wonder, well, what does it make? What are the qualities, the characteristics for any of these diseases to actually make it to the list? And we're going to go briefly through that. So what exactly does it mean to be a neglected disease? Who is neglected? What does it mean to be a neglected population? And then what can be done about it so that these diseases are actually out of neglect? So focusing on that very first important question, the WHO, a few years ago now, grouped together a group of diseases that even though they didn't really have a biological nexus, they did have some characteristics that made them particularly important. They mostly affect impoverished communities. They disproportionately affect women and children. But more importantly, they cause really devastating health, social, and economic consequences for the people that have it. And I think because of the challenges in public health control for each and every one of these diseases, they become really, really difficult because they create disability. And therefore, there is a much more lack of funding than for things and for diseases like malaria, for example, that causes great mortality and gets the attention of the funders and the public in general. As you can see here from this slide, the neglected tropical diseases as they stand today, it's a group of 20. This is an ever-growing list. So, for example, there are groups working on different diseases that want to make it to the list because, of course, the list is a public relations kind of list that then can get the attention of more funding and more groups and more young pediatricians and clinicians like yourselves to actually join the field. So little by little through the years, the list has been becoming larger and longer. And I actually had to put the fungi into this very lovely list of diseases, of infectious diseases. Mycetoma and chromoblastomycosis and dipmycosis just joined the list a few years ago. And there are still some diseases that haven't made it to the list for several reasons. It goes through a very rigorous process at WHO. But what you can see just by glancing at this list is that pretty much these are diseases that are prevalent in the tropics and subtropical areas as well, but not only. This is more the global distribution of all of these NTDs. And obviously what catches your eye right here is the African continent, as well as Brazil and Latin America. Most of those countries there suffer from at least 2 or 3 or 4 or up to 7 neglected tropical diseases in really disproportionate measures. But then you go into the countries like Asian countries that may have less amount, but the burden of disease can be quite strong as well. When this is actually on the map on the other side gets to the GDP of every country, you see very unsurprisingly that these diseases affect the poorest of the poor in across the world, really. But who is neglected? So are every community in these countries affected the same way? Because of course, you know, the parasites, are they going to choose who they actually affect? And I can tell you very confidently that children are a neglected population within neglected diseases. This is a very recent study that came out that illustrates this point very eloquently, because it found that children contributed up to 36% to the $20 million resulting from having an NTD, any NTD. But pediatric trials, so research trying to answer questions, to have better drugs, better dosing, better treatment for these diseases, only contributed 17% of all the trials. So of course there is a mismatch that you see. I'm sure you've seen this in other areas, in other sectors as well, but definitely in NTDs you see it dramatically. Interestingly, the only, if you look at this graph right here, the only NTD that seems to have more trials in children is schistosomiasis, which is actually the field that I work in, and the field that where we're trying to get more pediatricians in. So I guess there is some hope in the field. But there are some chilling statistics, and even though these ones are a few years back, Peter Hotez is a pediatric infectious diseases doctor from the US and one of the greatest advocates for NTDs that has really propelled that advocacy in the last decade, really. If you look at these numbers, 876 million children that require deworming treatments for 1, 2, or up to 7 of these parasitic diseases, 276 million people, children and adults, will require just for schistosomiasis alone. But you have up to 1.2 billion that require treatment for lymphatic filariasis, although I have to say that the control programs are getting better each day for LF, but we have more than 10,000 children dying from these conditions, and sometimes is really the synergistic effect of all of this, plus then bringing in something like malnutrition that will then put these kids at risk for mortality. So the public health ability to interfere of these diseases with child growth, physical fitness, and cognition is really huge. And so we have to bring them to the forefront to bring them out of neglect. And I think that this is probably the take-home message that you should all take home. That is, anybody, any children living below the poverty line, which is set at $1.25 per day, requires NTD treatments. That really sets the stage of where these diseases happen. And then now going into the recognition of the disease, now putting our clinicians' hats on. Of course, when you look at the women, the adult women that you have here on the left, you clearly see elephantiasis and lymphatic filariasis. When you see really all the campaigns, and even when you study in clinical medicine, this is really the image that sticks. And this is the image that then will have the control programs take care of it as a disease management. So they give drugs for lymphatic filariasis, ivermectin, but will also do case management of the elephantiasis. Now, when you look at the kids on the other side, and these are pictures taken by me many years ago, they look fine. These are children that really don't have it anywhere where you can actually see, unless the mother agrees to have the child examined, like it happened in this particular case, and you find a hydrocele. So you may say, well, this could be just a hydrocele. Well, this is a bilateral hydrocele that ended up being LF because we were able to diagnose it with an antigen test. And so this is a very early manifestation of an NTD that could be treated in early childhood. But unfortunately, the drugs for early childhood are just not there. You have to be 15 kilos and above to get ivermectin, for example. So there are really huge gaps in treating children and young children to then prevent those morbidities. There is a push, of course. It is recognized that these diseases do affect children, but unfortunately it's just not enough. Same thing with leprosy. So of course you see the very advanced stages of leprosy, which is another NTD. And when you get to those stages, even if you have the multi-drug blisters and treatments that are available, many times it's just really very late and the limbs are lost, etc. But when you have children, on the other hand, that also have leprosy, this is really the time to diagnose it early, to treat it early, to have those surveillance campaigns. And again, the will is there, but the resources are still not allocated massively. So this is a patch, for example, for leprosy. So this is a hypoaesthetic patch. So essentially anesthetize that will give you a hint that this is early leprosy. And one of the most striking quotations that I read recently was from Dr. Irving Corman as a team leader of the WHO Global Leprosy Program that really pointed out at this neglect in children, that the world has the tools, the right medicines, the political will, but we are failing short of detecting leprosy in this particular case among children. And again, just re-emphasize the importance of follow-up, contact tracing, monitoring in a household where a case is detected. And that's really where the chain gets broken many times. So that's another example. But I would like to take this opportunity in the few minutes that I have just to focus on preschool children, because this is a population that actually does get neglected, as I showed you with lymphatic filariasis, and bring the case of preschool schistosomiasis, which is very dear to me, since this is where I mostly work in Uganda in a clinical trial, trying to optimize the right treatment for these little kids. Where do they get schistosomiasis? From infected water from the lake. The lake is the primary source of water, where the mothers, and they help to get water for bathing, for swimming, for cooking, for everything really. And of course, these two children, A and B, are African children in Uganda, but the little guy on the other side is from the Philippines, because of course, this is a disease that is not only prevalent in Africa, but also in Asia, in some countries, as well as Brazil. And the old views that the field had when actually I joined was that the children seen as reservoir of infection. They didn't seem too bad. When you looked at them, they run, they went to school, they didn't really look very diseased, meaning fibrotic disease, because schistosomiasis can really end up giving a lot of end organ damage from fibrosis. But what we realized in the last 2 decades is that they all suffer from functional morbidity. And you will understand very well what that means, because of course it's anemia, it's growth, it's physical fitness, it's overall well-being that then will lead to fibrosis. So there is definitely time to act early on. And why is this infection different in children? Well, there's a pro-inflammatory state due to schistosoma infection, which is the parasite that gives rise to schistosomiasis, and that impairs normal growth. Anytime you have any kind of inflammatory insult, there will be a trigger down the inflammatory cascade, and that will inhibit linear growth. And this will manifest clinically as stunting. Now, it will also give anemia, and not only anemia, so it will give anemia of inflammation as well as iron deficiency anemia from losses. So it's a combined effect of this anemia that, of course, will lead to decreased cognition, decreased physical fitness, and overall well-being as well. And then if you see the timing when this occurs, it all starts, of course, in preschool years, when this infection happens, when these children are getting exposed very early on. Now, for schistosomiasis, the treatment used to be from 6 to 16 years old. So the school age years was that what WHO used to recommend. And you had that window of catch-up growth from stunting all the way to the fusing of the growth plates, when, of course, the child can no longer grow. So very, very short window. And there's a vulnerable period there of no treatment at all. And of course, you can all realize that that's a period where it would be just absolutely amazing to get praziquantel into these preschoolers. And the good news is that actually WHO has finally agreed to treat preschool children just as of last year. And all this will lead to decrease adult productivity in the end. And I also used to always hear these things that preschool children actually didn't have fibrosis. Well, it's true that they have less fibrosis than adult children or older children rather, but you can find like this little guy, 4-year-old boy with stage C liver fibrosis. It's a type of fibrosis that we see in schistosomiasis. So it's not true that it's not there. You just have to look for it. And we had a pediatric trainee working with us in Uganda, Sophie, that did an ultrasound analysis on children 1 to 4-year-olds. And what you see here in the ultrasound outcomes is, even though the percentages are small for the things that matter, like the thickened portal veins, fibrosis, rounded caudal liver edge, and so on, these are actually children that are very, very young. So what we realize is that, of course, there is incipient fibrosis going on. And there are some children that are already having fibrosis. So, of course, it takes no genius to say, well, let's just treat them when they're very young to avoid further outcomes and further progression of the disease. But in a bladder disease, which is a different kind of schistosomiasis, we also find preschool morbidity. So this is a bladder, and these polyps here are granulomas of schistosoma eggs. And as you can see here, is very detectable morbidity. So it's not true that they're actually living without disease. And it is really 6 years before they get the first treatment. And like I just mentioned, the WHO just changed the guidelines. Right now, we can treat preschool children. There is a bit of a bottleneck because we still don't have a pediatric formulation, although that is coming. And what we have to do is just to crush the tablets, which is actually really, really well tolerated. So what can we do about it? So it was a whirlwind of NTDs as a group and so on. But what are the things that we can do at high level, at individual level? And the WHO has an NTD roadmap. And this NTD roadmap, they had set up goals to tackle between 2021 and 2030. And those goals, of course, refer to the Sustainable Development Goals. As you can see here, number 3, which is good health and well-being, really pertains to NTDs as well. But it really cross-cuts across the other domains as well. If anybody's interested, this is really supposed to whet your appetite to say, oh, well, what about girls? And what about gynecological health in adolescents and STIs and all of that? Well, all of that really has a place in NTD control, in NTD diseases, and as part of the umbrella of this NTD roadmap. The new pillars for this NTD roadmap are really, really interesting. When all these NTDs started really catching the attention of WHO, of the funders, of ministries of health, the programs were very, very vertical, meaning donations, going into the field, treating, and then leaving. But now with this new roadmap for NTDs, the impact, the assessment of the impact is very much looking at integration of intervention. So, for example, it's not just one parasite that you want to treat several of them together in a school program, which is much more beneficial. But then at the same time of this holistic approach, there is definitely country ownership, which means, yes, of course, you need some input from vertical programs, from donations, from big funders. However, the country has to own this issue and then be more programmatic and more effective in how they budget to actually tackle the NTDs. And that really is a big ask. But there are some good statistics as well. So from this particular report, 600 million fewer people require interventions against NTDs than in 2010. So definitely we are gaining momentum, and it is not a bad time to do that. And then another thing we can do about it is go to guidelines. So of course, I go back to schistosomiasis, which is the one that I know the best. And we wrote a small review for clinicians that have no idea about schistosomiasis, and then what to do about it, when to suspect it, what to do about it. But you do have these kinds of guidelines bringing the NTDs a little bit closer to the clinician, a little bit closer even to school teachers that may pick up those kids that, again, may have more disability than any other thing to the table and to care. So really, thank you for having me, and hope that, again, you have whet your appetite on understanding these entities a little bit more, a little bit deeper. But some take-home message could be, always know that children are definitely a neglected population in all entities, even though it affects them disproportionately. We need more pediatricians, we need more teachers, we need more critical mass focusing really on children. It's pediatric research, is pediatric implementation of programs. So even if it's not academic research, it can be through NGO work, for example. So NGOs work hand in hand with Ministry of Health, delivering NTD treatments, for example. Diagnostics, I can tell you, I could go on and on about diagnostics and surveillance, but there are many things and many gaps that we still have in diagnosing these NTDs in the field, and particularly to children. And then again, more pediatricians, more people like yourselves. So with that, this is actually a picture treating preschoolers with crush tablets in the field, and then showing them that it can be done safely and effectively. Thank you very much.
Many thanks. Sorry, there's a little bit of feedback. Many thanks, Professor Bustinduy. Some incredibly powerful statistics about these actually very prevalent diseases, despite being called NTDs, and how they affect these deprived populations and children. I'd like to invite you to keep your camera on, and we'll invite Dr. Wariri back to the stage. Unfortunately, I'm very sad to say we're unable to welcome Dr. Bialicki today. She's unable to join because of an unexpected emergency. But we're looking forward to a wonderful discussion with our other speakers. Just going to check. Okay. So I'll to start us off, shall I ask some questions to Professor Bustinduy? There's so many thank yous in the chat. I'm not sure if you're able to see that already. But just to start off, many of us have little training and exposure to NTDs in our training. So how would you recommend that we learn more about these conditions and include them in our differentials?
That's a fantastic question. So if you really want to learn about these diseases, well, we have an NTD module at the school. It's not that I'm doing a little bit of PR, but definitely get training. There are courses out there where you can actually learn about them before going to the field. Another way of learning is when you work with NGOs, or where you're posted somewhere, and that's where you can learn sort of locally. But if you want to educate yourself, there's courses. There's definitely courses where you can learn deeply. You gave me 20 minutes, and it was absolutely impossible to go into all of them, but just an overview of what the group means, of what it is.
Wonderful. Thank you so much. It's true. There's so many online resources nowadays, especially. Another question. So you mentioned a sort of more integrative approach to NTDs rather than a vertical approach. So how would you recommend this is done practically?
That's the hardest bit. It's the hardest bit, but there is definitely a push to do that. So I'll give you an example, a very successful example, which is to integrate the control of soil-transmitted helminths, so Ascaris, hookworm, trichuris, schistosomiasis, trachoma. They all have different treatments, albendazole, praziquantel, azithromycin, but they're all delivered through school programs in endemic settings. Not only because schisto and trachoma also have a community base for some areas, I'm not going to complicate it, which means that if it really works, and this has to be centrally orchestrated from ministries, of course, then the delivery of the drugs is through the school programs. It's on a day that all the kids line up and they get their integrated treatment. It's never going to be comprehensive because you have diseases like lymphatic filariasis and leprosy, skin diseases that require a different kind of surveillance. But now I'm really happy to say that there is really a big push to do integrated skin disease surveillance, which is really, really exciting. And that, of course, will include scabies, leprosy, Buruli ulcers, mycetomas, as a more sort of syndromic approach to then get into the treatment. So yeah, we're always after integration.
Of course, just because I can't imagine how complex that becomes when you have the overlaying of all these different conditions and managing all of them at the same time and having to think about the interplay of the management and the interplay of making sure that they understand fully about their treatment. That's a lot.
It's really understanding the epidemiology, the local epidemiology is really paramount, because then you can allocate the resources to that particular area. So one area that has schisto will focus on schisto and STHs perhaps. But if there's no schisto and there's only trachoma, or they're brushing their trachoma, so that kind of mapping is so important to get good maps.
Makes a lot of sense. Someone has posted in the chat, just related to the earlier question, that there's some resources for pediatric infectious disease on the WSPID website. So I would recommend having a look at those. Another question. Thank you for a fab talk. How do you think climate change will influence the spread of NTDs in the future?
That's a very great question. And well, I'll give you a fun story regarding, well, fun, I don't know if fun, but anyway, quite a story. So schistosomiasis is always thought to be sort of more tropical disease and subtropical. However, because we have the snails in the Mediterranean and it's getting warmer, transmission is already been acknowledged in the Mediterranean. So, and of course you have that with dengue and all the viruses, they are coming closer because of climate change and warm weather. And so we're going to see mosquitoes. Malaria was in southern Spain way back when, So these things are coming back, and they're coming north, which, might be a good thing, because some people actually may start taking note.
Actually, very relevant to the earlier talk by Dr. Mavodza, and yeah, very, very relevant when we're talking about unequal distribution of resources and how things tend to suddenly have more resources when they affect more developed worlds. I have another question. If globally we improve the socioeconomic situation for these areas, so the areas where the NTDs disproportionately affect, through the SDGs, we're very hopeful. We have the target of eradication of poverty and inequalities. Would this help us to eradicate NTDs more broadly?
Absolutely. I mean, if you think of things like scabies, for example, where do you see scabies? You see scabies in areas where you just don't have enough sanitation, where people are living too close together, etc., etc. You improve the conditions, and obviously you start removing NTDs one by one. So absolutely. And this is really the only way to increase the living conditions. They are diseases of poverty more than geographical diseases.
Perfect. Thank you so much. The big question, is this achievable?
Yes, you have to be. I showed you a good statistic to close. You saw from 2010 to 2023, things have gotten better. It was actually in the London Declaration in 2012, where the commitment to from Big Pharma to start putting the tablets out there, like in the millions, that really started making a difference. And yes, of course, I think so. I think yes, of course we can. You have to think that, but we need more people, and we need more advocates and more everything, really, particularly pediatricians.
Perfect. And I think we can end on an optimistic note. We like to have these hopeful ending points. Thank you so much, Professor Bustinduy. We'd like to just say a big thank you to all our plenary speakers for both your time and really, really valuable insights. We're going to head off for a 30-minute break now. So it's if we say 25 past, then that'll make it 15:55. This is just because of the change in our timetable today. We'd asked participants to please remain logged in during the break, and we'll be back on the main stage at 15:55. And once you've got your cup of tea or coffee, if you'd like to come and meet some other participants in the networking session in the meantime, this will be at it'll be 15:40 that we'll be reopening the networking sessions again. So please do make use of those networking sessions if you can. Okay. Thank you very much
for having me, and good luck.
Thank you.